Terrific. Okay. Hi, everybody. I'm Dr. Anne Ramoyne. I'm the director of the Center for Global and Immigrant Health. Today, we're going to be welcoming Dr. Nicole Hoff, who's joining us live from the Democratic Republic of the Congo, which is really exciting to have her give us her perspective on what's happening in the DRC as it relates to COVID-19. I also think she might be able to give us a little bit of an update on what's happening as it relates to Ebola in DRC, and really just give us her perspective of what it's been like to live in a place like the Congo through the pandemic, being able to continue to do research and a little bit of information on what's actually happening on the ground. So Dr. Hoff is somebody that I have worked with for a very long time. She was one of my doctoral students, and she got her PhD at UCLA in the Department of Epidemiology. She is currently the director of the UCLA Center for the UCLA-DRC Health Research and Training Program. She's been in DRC for 10 years. She is an expert on all things related to infectious diseases in the DRC, and I'm very proud and happy to welcome her to be our leader of a COVID conversation today. So Nicole, take it away.
Awesome. I'm going to go ahead and share my screen. This one. Hi, everyone. I like to see a lot of the familiar names. As Dr. Ramoyne said, I'm just going to give a little bit overview. Oh, no. Okay. Of COVID activities and COVID goings on, and how it's affecting our ongoing research in the DRC over the next 30 to 40 minutes. So I was mentioning before the start of this talk how much I realized there just is really not a lot of information available for DRC on anything related to COVID. So I was really struggling to find really good statistics or comparative information. Even being here, there's just not data coming out or use of any sort of data that's being put together. So the picture here is basically what my life looks like every single day. Rarely people wear masks, even though it's mandated. There's little to no social distancing. This past weekend, I actually was in the field for a meeting. And at the airport, it was a lot of people inside of the building, no one wearing any masks. And then when we went outside to board the plane and we were standing outside because they were taking pictures because it was a new plane that we were boarding, they were like, "Oh, social distance." And I said, "Oh no." I was like, this is maybe the only place that it would be okay for us to be a little bit closer. I was like, "Where were you?" And I was standing inside trying to get my ticket with 70 people surrounding me. So just a little bit of background on DRC and some of the response to the pandemic. And then DRC is also, just in general, having a lot of competing pandemics. So just a little bit of background on the 2020 and 2021 Ebola outbreaks. And then as Dr. Ramoyne mentioned, talking about some of our ongoing research activities. So I've been in country since January of last year. Even though a lot of our activities really were reduced for a number of months. And then I'll take any questions and such that you guys have. So overall, the Congo is the largest sub-Saharan African country. It borders 9 other countries. The population is around 86 million. This is an estimate. You can find estimates anywhere from 74 to 110 million. Depending on the source of what you're looking at and who it's coming from. There hasn't been an actual census since 1984. So all estimates are really just kind of extrapolated estimates, mixed together estimates, all sorts of different types of estimates. The general life expectancy is 60 years, and the infant mortality ratio is 66 per 100 or per 1,000 live births. Recent studies have shown that up to 43% of children are maybe considered malnourished. 45% live in urban areas, so still the majority of people are living in rural and likely hard to reach, hard to access areas. And between 2018 and 2020, not only have we had COVID, but we've had a number of other competing outbreaks. So as I mentioned, the 2 Ebola outbreaks, we're currently in the middle of a vaccine-derived poliovirus outbreak that's been ongoing since, well, there's a number of different outbreaks, but 2017, 2016, but they've had continued new outbreaks that have popped up. Measles, we had one of the largest measles outbreaks in the world in 2019, 2020. Monkeypox is still having regular cases being reported. And then there's smaller regional outbreaks. Every once in a while, you'll hear of plague cases or yellow fever outbreaks or much smaller isolated outbreaks. And then also the eastern portion of the country where North Kivu is, and a good portion of the just eastern region in general is considered highly unstable and has a lot of different rebel group activity. So just to give you guys an idea of major events in DRC. So as you'll notice, most of my events are actually Ebola related. So we do have COVID here, but I mean, most of what we're hearing is really for other outbreaks. So the 2018 Ebola outbreak in Bandaka started in April, and they were able to start vaccination fairly quick. It was the first Ebola outbreak in DRC that used the vaccination. And then in July, that outbreak was declared over. In August, just a few days later, the North Kivu Ebola outbreak was declared, and that became the largest outbreak in DRC. In November of that year, they were actually able to start a clinical trial of 4 different treatments, and then was later able to reduce it to 2 different treatments. And that outbreak continued on through 2019. In March 2020, as the North Kivu outbreak was coming to somewhat of an end, the first cases of COVID were reported in DRC. So that was in March 10th. Really shortly actually after the first cases, our team, in fact, hearing kind of what was going on in the US, we actually started preparing for the possibility that eventually the country may close. Work would have to stop. And so we did a lot of things in our team to kind of make sure that we were able to move to doing work from home. We have a full functioning lab in DRC that requires a lot of TLC. And so we really worked hard to come up with plans before the outbreak really shut everything down in country to make sure that we were able to have one person come to the lab every day and just be in the lab to make sure that we had no major freezer failures where all of our samples are. And so we basically organized for them to be able to have private transport, 1 person per day to come to the lab to be sure that we were making sure that our samples were okay. And then at some point, lockdown measures did go into place. Churches, schools, events, everything stopped. And then all domestic and international travel also basically stopped. And so I actually don't live in this specific area, but Gombe is basically the heart of Kinshasa, the main city. And they completely closed off Gombe because they believe that's where a lot of the cases were. Early on in the outbreak, they were seeing a lot of imported cases as opposed to local circulation. And so their thought was to close off the area where the most expats and people that would be coming from international travel were. And so they actually closed off Gombe, which is right outside, like right, not exactly where I live, but really close. And then as all of these lockdowns were happening, then in June, the next Bandaka outbreak was declared, and they finally declared the end of the North Kivu outbreak. In August, mid-August, they actually opened up travel and started reducing the restrictions due to COVID. And so they had international travel and then domestic travel. But part of it was that you had to have the COVID test on entry and then also for leaving. In November, the 2020 Bandaka outbreak was declared over. In December 20th, mid-December, we started coming into our second wave. And so they implemented a countrywide curfew that went from 9 a.m. to 5 p.m. and mandatory mask restrictions. We'll talk about that a little bit more in a few slides. And then just a few weeks ago, we had a new Ebola outbreak declared, which is ongoing currently. So overall, since the beginning of the outbreak, there's been 25,000, almost 26,000 cases reported, identified, and 707 deaths. I'd be willing to bet there's like one huge spike in the number of deaths in one day. I'd be willing to guess that that's over a number of days kind of aggregated together as opposed to one day deaths being that high. And so as you can see, really here, we were waiting. And I guess that's like the only way I can say it was that I was just waiting for what we saw happening in the US. And so in March and April, sorry, my daughter's supposed to be in bed and she just came sneaking out. But in March, April, and May, when we were in lockdown, we weren't leaving the house, and I was just waiting to see explosions of cases, knowing that outside of kind of this bubble that I live in, that people were really going about their lives as normal. And so we would talk to our colleagues who are also really, we were really strict about making sure that they stayed home, worked from home, giving them the ability to work from home. But we were asking, what's going on in your communities? Are you hearing rumors? Are you hearing about cases? Are you hearing about anything going on? And we just really never saw that. And even as we've kind of entered our second wave, I hear now a lot of stories from expat friends or from different expat WhatsApp groups that I'm in of the number of cases where a lot of expats have had COVID, but a lot of our Congolese colleagues are like, nobody, we don't think it's here. I think we think it's over. We're not sure where these numbers are coming from. So it's just been like a really interesting time of trying to figure out why we're not seeing, we are seeing an increase in cases, but there's nowhere near kind of the explosion of cases that we watched happen in the US and Europe and a number of other places. And even still, and some of this has, to do with issues of testing, availability. And so Kinshasa, I don't know if you guys can see my mouse or not, but Kinshasa is here. Kinshasa and North Kivu really have seen the most cases. Lubumbashi has a lot of people coming in from Zambia, South Africa through their land borders, which are not closed right now. But at this time point, we still have 4 provinces of the 26 that haven't reported any cases. And, of course, there's issues of underreporting and testing availability. I'd say these 4 provinces probably have the lowest amount of testing ability. So in order to get a confirmed sample from these areas, you'd have to have the sample somehow shipped to Kinshasa or Lubumbashi or Goma where they're testing. So for sure, I think these are underestimates. But looking at all the other information that we have, I'm not sure how much higher the estimates are, but we're not seeing an overwhelming people going to hospitals. The health system isn't any more taxed than it normally is. I mean, the health system here is a really fragile system. And so you would assume that any changes would have a really, really huge impact on any type of functioning of the system. And I'll talk a little bit about kind of certain things that we've done with some of our recent hospital studies in Kinshasa in a little bit. But in general, we're just not hearing about an overwhelming use of hospitals. We're not hearing of overwhelming people hiding people. Like you would hear in the North Kivu outbreak for Ebola, that there was a lot of community circulation because there was a lot of misinformation and mistrust from the Ebola outbreak. And so in the communities, people were hiding people that were getting sick, but you would hear these rumors, and we're just not hearing the same types of rumors related to COVID-19 here. And so in general, testing is done as requested at this point for symptomatic individuals and those that have come in contact with confirmed cases. But I'd say sometimes it's hard to find a testing site. Sometimes there's a long wait. It's more of like you requesting a test as opposed to it being required. And if you are tested and you come out positive, there's not really any contact tracing going on at this point or following up of sick people or anything along those ways. And as I mentioned before, we're just not hearing hospitals reporting being overburdened. As I mentioned, I was trying to look for data. I had the chance to see Devorah's presentation and saw all of the awesome data and statistics that she was presenting on COVID. And I was really shocked that I could find almost nothing of the same type of information for DRC. I'm sure if I went and looked through emails and all of my other things, I could maybe find the number of people who are tested compared to the number who have been positive. But really after the first few months, reports just kind of stopped coming out. And testing is required when entering and leaving the country. And then additionally, now when you come into the country from an international travel, you are also tested. But, there's some uncertainty on the protocols. Different locations will say different amounts of days. And then there's limited following up on any positive cases. So at some point, right around the time we entered our second wave, the travel testing started seeing an increase in positive cases. So people coming that were planning to travel within 2 days who turned up positive. But there's really limited follow-up. Nobody checks in to make sure these people are isolating. As I've mentioned, I've had a few friends here who have gotten COVID. And after they test positive, they have no other contact with anybody to actually confirm or check that they are following quarantine, who they've been in contact with or anything along those lines. Currently, we have a curfew in place from 9 p.m. to 5 a.m. In fact, in some ways, especially in Kinshasa, this actually has caused areas that are normally dense throughout the day and night to become even more densely crowded because people are rushing to get home. In some ways, this has become kind of a police ability to take stuff or to get money as opposed to actually enforcing it because it could reduce people being out. So it's not really enforced uniformly. As I mentioned, I was just in the east of the country in Kalimi last week, and there they basically said nobody follows the curfew. It's just not something they do, but they also said they've only reported 6 cases. So there's a lot of wide variety of what's really going on. There's mandatory mask mandates, temperature checks, and social distancing required in all locations. This really is not enforced locally. And it's interesting because, I see everything that's happening in the US. And so, I'm wearing my mask and somebody will stand right next to me. And I'm like, distance. And people will be like, why? Why do I need to distance? And I'm like, anyways, you could just stand a little bit further away, even if we weren't in a time of COVID, but really, you don't have to stand so close. And it's interesting because the first few weeks after COVID started, when we would go to the grocery stores, they had the social distancing marks where you would stand to try and distance when you're standing in line at the grocery store. And, when they lifted the restrictions for being able to move around and opening up Gombe, the main part of town, I think people just assumed that meant that COVID was over. And so any type of social distancing at the grocery store completely went away. And so it's really been an interesting conflict of what do I do, and how do I handle these situations of being in an elevator where it says only 3 people should be on the elevator, and instead 7 people have tried getting onto the elevator and no one's wearing a mask except for me. And so it's definitely a really conflicting situation of what the right thing to do. Recently, in the past few weeks, the DRC has been putting together their plan for COVAX, which is the Gavi-funded program for getting vaccines to low and middle income countries. So I'm not entirely sure when COVAX will roll out in DRC. I know that they've sent vaccines already to Ghana and Ivory Coast. And we hear that even as early as the next few weeks, the DRC will start having their first doses of vaccine. And so it's been interesting to be a part of some of those phone calls where they're trying to think of who they should vaccinate, who's the primary category, where do they start, do they look for comorbidities? Dr. Moyne and I were just talking about this yesterday, of the kind of interesting process that we're seeing happen for this. And this slide I took from Devorah's presentation because it really is true. As I mentioned, I've been waiting for this explosion to happen here. And, there's probably a number of different reasons of why we're not seeing this explosion. But I think, normally the DRC relies on higher income countries to support a lot of the research that happens here. And so a lot of that research support is being geared towards their own countries. And so there's just not a lot of research, especially towards COVID, being done here. And so, as she mentions, there's just a lot of hypotheses. There's not a lot of work that's necessarily being done specifically in these areas to figure out why we see less cases. They talk about the age of the population. As I mentioned, the average life expectancy here is currently 60 years. So our population is just younger. Lessons learned from previous outbreaks, not sure how much that qualifies for DRC, maybe. Time to prepare, again, I don't know how much this has in DRC. There's been a lot of discussion of what the BCG vaccination could be contributing to some of the lower rates that we're seeing. The DRC is a country that's vaccinated for tuberculosis with BCG for a number of years, basically since the start of their EPI program. And then resistance due to exposure to other coronaviruses. I mean, a lot of our work is focused on looking at emerging viruses from animals. And so we know that there's coronaviruses that circulate here. We also know that in general, a lot of the populations are exposed to so many things. In a lot of our Ebola work, we've seen when you try to look at animal exposures that there's no usually one animal exposure that pops out, and it's because so many people report that they've had so many different exposures to just so many different types of animals that it's hard to disentangle this web of who's been exposed to what to say, oh, this could be the primary risk factor. So I think, as the vaccine is rolled out more so in higher income countries, hopefully that we'll be able to focus again on to why we're not seeing these explosions happen here. And as I mentioned, there's been competing outbreaks going on. And so it's also been interesting because typically you would have a lot of expats and foreign personnel coming and for helping to handle these outbreaks. And this has been really limited in these past 2 outbreaks. So in 2020, there was the outbreak in Bandaka, which had in total 130 cases. This one is somewhat interesting because due to the genetic sequencing, they were actually able to see 2 different potential sources of infection. So they were able to identify cases that indicated that it was a new spillover event. So a new event happening where a person had contact with an infected animal and then had community transmission. And then they also were able to find other cases that had direct linkage to the 2018 outbreak. So possibly persistence or sexual transmission or relapse. These are ongoing questions. And one thing that we see here is that, there are a number of really, really great researchers here, but there's not a lot of them. And so they're all being tasked to deal with all of the different outbreaks. And so their time to be able to really delve into some of these topics and be able to really put out a lot more information on it is limited, because as they're putting out one fire, they have 6 other fires starting in the background. And then the most recent outbreak was on February 7th, with the new cases in North Kivu identified. And this one has, a lot of implications for understanding how the vaccine is really working and what is going on with Ebola. The original woman infected was the woman of a survivor. Wow, I'm really sorry. That's not the correct English. Sometimes I think in more French. And do not express myself. She was the wife of a survivor. And the survivor was actually a part of some of the long-term survivor studies, and so had regular sperm samples taken. And the last 2 sperm samples that were taken in September and November were actually negative for Ebola. However, when they did the genetic sequencing on the woman's sample, they actually see that there is really limited genetic differences between the husband sample from 2019 and now, indicating that it's likely a persistence of infection, which really raises more questions as to how could he have 2 negative sperm samples and still have, this infection come back. So far, there have been 8 confirmed cases with 4 deaths and is considered ongoing. And something pretty impressive was that vaccination was able to start really days after declaration of this outbreak. And so they've been really quick to act and get vaccinating and trying to prevent the spread of this outbreak. And so now on to some of the work that we've been doing. So as Dr. Amoyne mentioned, I've been in DRC. I've been based here almost 10 years in August. Right now we have 4 primary studies that we're working on. The top 2 are working specifically with Ebola survivor populations, vaccinated populations, and high-risk healthcare workers. So healthcare workers coming from these areas that have had previous outbreaks. We additionally have a introductory pharmacovigilance study going on in Kinshasa that's using archival records, and then has additionally had a prospective data collection phase. And then really kind of my longest part of work that I've done here has been on vaccine preventable diseases. And so the last project we have is doing the evaluation of the routine immunization strengthening program going on in 2 provinces, where we do coverage surveys and look at a lot of sources of data coming out. So once COVID started or was declared in March, we stopped all field work entirely. As I mentioned, we had a little bit of advance notice that we likely would move to this phase. And so we had interviewers who were in the field specifically for the pharmacovigilance project take pictures of everything so that they could continue data entry from home. And then everyone else we had moved to working completely at home except for our lab team, as I mentioned. However, once travel opened in August, we felt comfortable enough to do a few things. One, we completed 2 missions for our Ebola-related studies. So we went to Kikwit in November of 2020, and then we went to Bandaka to do the 2.5-year follow-up for our vaccinated participants. So 2.5 years post-vaccination. So the top picture is our interviewer working with our teams. As much as we could, we encouraged all of our enquêteurs to wear face masks and wear them correctly. The bottom picture, you'll see this was not always the case. But a lot of times the people that we were working with didn't have face masks. We added COVID modules to all of our surveys that we were working on to try and get an idea of how many people were wearing face masks and how many were wearing them correctly, and symptoms and a number of other exposures. And overwhelmingly, people are saying, oh, COVID is over. despite the fact that as this was going on, we were moving into the second wave of cases happening. So the second picture is going through all of the archival records and getting the pictures and trying to figure out what's going on with the data. So our studies with hospitals and maternities, for the March to August, we were just doing retrospective data entry. And as I mentioned, we took pictures of everything we needed. In August, based on working with a lot of the hospitals, we were calling hospitals. We had weekly check-ins to assess the risk in the hospital. So 2 of the hospitals had areas that they were triaging COVID cases. And so we actually had some delays in going back to those hospitals, but all the other hospitals that we worked with, A, were not considered COVID treatment centers, and B, did not see any increases in any type of diseases or COVID-related diseases. In those questionnaires, we also added vaccine hesitancy modules and then COVID-19 modules. So symptoms, CAPS, knowledge, attitudes, and practices, and some other questions to try and understand more about these populations. In addition, once we were kind of going through all of this, we realized that we had a number of really interesting cohorts that we had been collecting from since 2015, and this is our healthcare workers. So over the past 5 years, we've done a number of cohorts enrolling healthcare workers in different areas. So we decided to basically pull from those old cohorts and people that agreed to participate in future studies to do a biweekly phone survey. So we chose locations where they had phone communications, although my team would say Kikwit, Bini, and Bandaka do not always have the best phone communication, but we've been pretty successful to date. And we just last week finished actually our 6-month follow-up. So during that questionnaire, we asked questions related to demographics, clinical disease and symptoms, occupational exposures, community exposures, and then a whole section of CAP based on the WHO snapshot COSMO modules, which includes vaccine hesitancy modules. And so our plan is to continue collecting this data biweekly for the next year, or for the next 6 months to get a year's worth of data. And so we basically have the questions divided that some questions get asked at every time period, so that we can look at changes over kind of the shorter time period. Some questions get asked every 3 months, and other questions we're only asking on a much less frequent basis, so once every 6 months. So we're really excited to start getting this data out. Right now, as far as I know, there's been 3 or 4 publications related to COVID and CAP that have been published that have been fairly limited in their ability to say much. So we're really excited to see where this goes. And actually, that's the end of our presentation. Just to say that, a lot of this work is not just done by us. We have a lot of really great collaborators here that we work really closely with. So the Kinshasa School of Public Health, the Minister of Health, and the EPI, and then where our office is based, actually the National Institute of Biomedical Research. And yeah, that is my presentation. So I'm happy to answer questions and chat more.
Nicole, this is a really terrific presentation. Thank you so much for sharing your perspective with us. It's really, really terrific. Can you tell me, I'm just curious from your perspective, what's surprised you the most about the situation with COVID in DRC as compared to what you're hearing? I mean, you haven't been here for any of it, but what are the things that have surprised you the most?
I mean, I feel like when I see the news in the US or see of the numbers of cases, it feels like you could go outside and be exposed to COVID if you were in the US. And so I just think of like every day when I go outside and how many people I see and how much we're just in contact with people. And I mean, I sometimes think it's somewhat amazing that we have a team of basically 14 full-time staff, and then when we had the pharmacovigilance study, an additional 14 people, that we haven't had one COVID case in our team in almost a year. And I know, like, I have no explanation for it, because I'm sure that there's people on our team that are not adhering to things once they leave the office. And so it's just been a really interesting thing that, like, I can't figure out. Like I said, I just traveled to the eastern part of the country over the past few days, and in the airport, I mean, nobody's wearing a mask. And going into the provinces, especially like where our teams were in Kikwit and Bandaka, we're all wearing masks. And so it's like an interesting thing, because you always want to like feel kind of like you're assimilated in the research and really participating with people that you're working with. And in our heads, we're like, no, we always have to wear masks. And so it's interesting, I think, also for our teams that are not used to like having a different relationship with our participants, to not make them feel different, that now we all have masks on, and no one else is wearing a mask. So yeah, it's definitely an interesting conflict. I'm like, do I need to wear my mask all the time? But I do.
That's right. Now, you actually also had your parents visit during COVID, and it must have been very surprising to them also to be able to see the difference of what it's like in the United States versus what it's like there in DRC.
Yeah, for sure. Like, they just hadn't seen so many people in so long. And I mean, it was a really hard decision for my parents to come visit. But I have a daughter, a really young daughter, and my parents hadn't seen her in a year. And, it's becoming like a mental health issue on their part, of like not being able to have any interaction with her. And so we like spent weeks planning before they left, of them basically quarantining in the US, not seeing anybody, and then taking as many precautions as they could on the flight here. And then we really didn't do anything once they were here, except for them getting to play with my daughter. And so, but in general, like, of course, they had to come into the airport. And so just like seeing so many people, I think, was probably like just overwhelming to them, because, I mean, our lives have basically continued. I mean, we have indoor restaurants that we go to. There's play dates, and then children are going to play on jungle gyms and inside. And yeah, I mean, my life is somewhat normal, with the addition of wearing a mask when I'm going to and from places. But other than that, yeah. Sorry, everybody. I feel bad telling you all this.
It kind of brings up an interesting question too, Nicole, about why the expat community has had cases at a much higher rate than the Congolese community. And it honestly makes me wonder, given, how little adherence there is to masking and other things like that, if it's really kind of a baseline, of those list of hypotheses you were mentioning, that it's probably much more likely to be something regarding exposures in the Congolese community that have given them some kind of baseline protective protective measures, whether that's coronavirus exposures from all the animal exposures, or whether that BCG vaccine is really doing something protective there. But that certainly says to me that it might be circulating in the community, and it just doesn't seem to have the same severe disease or hospitalization rate associated with it that it's having in high income countries.
Yeah, absolutely. I mean, I don't have a lot of friends here, but I have one friend who now has had COVID twice. And I mean, just in general, you'll hear the discussion within the expat community, much more of COVID circulation, just being a part of certain WhatsApp groups. it's definitely a lot more of the discussion. Every once in a while, I mean, obviously we've known a few Congolese colleagues who have gotten COVID or passed away from COVID. There was like a period in time, and maybe when was it? Maybe June, that like the EPI program had COVID circulating and the INRB had COVID circulating. And I mean, that's really the only time that I've heard of COVID at much more kind of circulating within local populations. But both of those groups are seeing a lot of international colleagues as well during that time period. So yeah, definitely, who knows?
Other questions?
Yeah, I just mentioned in the chat, I'm also wondering the lifestyle habits. Americans are not very active, and our diets are very different than, I'm assuming, the community there, and they're probably more active than Americans. I'm also wondering if that's a contributing factor.
Yeah, I mean, there's so many things that really could be a contributing factor, but as I mentioned, like there's really no research going on onto any of these reasons right now. I mean, there's ideas and there's possibilities. Like, I mean, looking at the younger population, it definitely is a younger population, but I mean, just in general, you would assume there's certain comorbidities that are at a higher rate here. Malnutrition, for example. There's a huge amount of malnutrition, but yeah, the community probably is a lot more active. People are walking and definitely having to do a lot more maybe strenuous work. Yeah, definitely. The population is definitely probably less sedentary here. Is there one more chat question?
Yes, I just, thanks for the amazing presentation. I guess I just wanted to know, like in general, what has been the most challenging part of doing research in the DRC? Because I'm from Gabon, which is a neighboring country to the DRC, and I know there are many challenges of doing research in a resource limited setting. So I guess I just wanted to hear from your personal experience, what it's been like to do research just in general there, and even now with the pandemic going on.
Yeah, so I'd say pre-COVID, some of our biggest challenges were like logistical challenges. I mean, I'm an epidemiologist, but somehow when I go to the field, I'm also an electrician, a mechanic, like I fill in like 100 different positions that I like never expected that I was going to have to do, like calculating on a generator how many different things you can place, or if we have to run a centrifuge, that's a really big centrifuge. How do you run it and not blow out the fuse on everything that you're doing? So like really just like basic logistical challenges have always really been a struggle. Interestingly enough, like going to the field, and especially like once you're working in more rural populations, like participation, people are really interested in what you're doing and why you're there. And so they're willing to participate. So, I mean, a lot of times our studies will have really low refusal rates in general, because people are interested in seeing what you're doing. So participation really hasn't ever been an issue. Post-COVID, thinking of doing a phone survey, I was like, this can't be that hard. We already have their phone numbers. We've met them before. But interestingly, a phone survey has been one of the most difficult surveys that we've ever done here. People are really, really weary about participating in phone surveys. One of our questions asks if a woman is pregnant, and nobody wants to respond to this question. And so we had quite a few more refusals for the phone survey, or people wanting to continue with it because they couldn't see you. And so it was a really interesting thing and kind of unexpected that we would have any issues in doing a phone survey, just because all of our studies, we've always had really, really high participation. For example, our team in just completed the 2.5-year follow-up for people who were vaccinated against the Ebola vaccine in 2018. And for the vaccinated population, we were able to find 76% of the original participants. Our healthcare workers, we were able to find over 80% of the original healthcare workers. Community members were a little bit lower, but that's a much more kind of fluid population that oftentimes didn't have phone numbers. And so I think we had 70% follow-up. And basically we've had to readapt our teams in how to do follow-up in a population where people don't have phone numbers. So certain things I think like that have been really interesting challenges. I'd also say sometimes writing studies in terms of like how you would conduct a study in the US to be able to get it through certain IRB approvals, and then the reality of what's going to happen in the field. We do a lot of polio surveys that aren't collecting sensitive information. And when you go into a village, the moment that you say, oh, we want to take you into a private room to talk with you and your family about this, everybody in the village is watching and they're like, why do you want to talk to me in private? What are you going to do to me in private? And so then there's a huge amount of distrust within the community. And so I think those have also been interesting challenges to overcome, how you kind of bridge the ethical concerns that you would have for doing a study in the US versus the cultural concerns of doing some of these studies. Has definitely also been interesting challenges of how you bridge those two aspects to make sure that you're really respecting the participant and giving them as much privacy as they want to participate, and not feeling that there's any type of coercion or that they have to participate.
Thank you.
Can I ask kind of a follow-up to that? And where have you found success in getting that follow-up? And I know it's gonna be really challenging. Some folks, as you mentioned, cannot be reached easily, or their lifestyle, just they may come in, you may be able to collect a sample, they've gone through consent, and now we're looking for somebody 6 months out. Have you found any sort of operations or any procedures that just create a higher success rate in getting people to return?
I'd say, so I'm here as an expat, but everybody else that I work with here is a fully Congolese team. And when we go to the field, we also hire a fully local team who really knows the population, and oftentimes will work with healthcare workers who know really huge amounts of the population. And so I think having that local integration into our study and having them be kind of a part of the study definitely helps, because they'll be like, oh, this person's address is here, but I know they moved. And so I think having that kind of an integration has helped. And oftentimes when we've enrolled people, we've asked them for like their friends' phone numbers or somebody else's phone number, so that like there's an additional person to contact. And so, of course, that brings into a whole different thing of like, if you're contacting a different person to ask about it, what information do you share or not share, so that you're not providing like personal information about the person. And then we've also figured out how to like have our local teams really like basically be in charge of a few different people, especially if we know that they're a more mobile population. But I think definitely the local involvement is pretty key in those follow-ups.
Great. And how are you I know that consent can be challenging just because there's, regional dialects and locality and things that people accept, and I think it's always a really challenging thing dealing with populations that have maybe, I've been in a place where there was, 100 plus local dialects, and we try to find someone who is a local speaker, but that can be really challenging. And we felt there was people that needed to be turned away, but then maybe they're one of the only people who came in who would be a great candidate, and we'd like to continue working with. So how do you approach those things in the field, as opposed, I know like it's in a perfect world, and then being operational is not always the same.
Yeah, one of my favorite stories is that, like, for example, the DHS has to publish their questionnaire in all the local language, like the official local languages. So in DRC, they make a French questionnaire, and then they'll have a Lingala, Swahili, Chiluba, and Kikongo questionnaire. But like even within those 4 dialects, there's so much variation. And so they'll print off a Lingala questionnaire and then they send it someplace where like nobody uses that specific dialect of Lingala. And so, I mean, we'll typically always have like a local language questionnaire, but in fact, in our training, we do a lot of training with the French questionnaires or the French consents, and then we'll practice them in as many dialects as we can try and cover. And so we'll ask our interviewers like, okay, well, how many different dialects are there? And so making sure that they practice the questionnaire together. I mean, I remember in the DHS at some point, I was in the field and I was looking over their responses for the questionnaire, and there was a question that asked like, has your child had measles? And then at what age? And I'm looking through all of the questionnaires and every child has had measles at 9 months. And I was like, I'm sure they're asking this question, have they been vaccinated? And so when I asked them to tell me the question, they all read it to me in French where they said it correctly. And I was like, okay, but how are you asking it? And they're like, well, you're not going to understand. And I was like, right, I'm not going to understand, but we're sitting here with all of your peers. They'll understand what you're asking. And so sure enough, they asked the question how they'd been asking it in the dialect they were using. And every interviewer in there was like, oh no, you're asking this question. You're asking if they've been vaccinated. And so I think that's been a really kind of important lesson of when we're doing our training to really spend time of the group discussion of the questions and making sure that there's practicing it in local dialects, because in the end, most people will always prefer, especially healthcare workers and kind of a higher level of not necessarily education. I mean, a lot of ours are nurses or relais communautaires, but they all prefer to use a French version, and then they translate the French version into their more local dialects, because I mean, a lot of the languages really aren't written languages. So giving them a written questionnaire in a language they don't normally write, I mean, is almost useless. I mean, they kind of laugh at us when we give it to them. They're like, what am I going to do with this?
Awesome. Thank you. And not to take too much, but just in that follow-up, have you come across some things just like that where local teams have come up with solutions that are often maybe better than our own, or something that you came prepared and they said, that's not going to work because of this, and then they pivot and they give you some option that's really successful, or anything like that?
Yeah, to this date, when we started talking about doing electronic surveys on tablets, everybody was like, it's not going to work. The tablets are going to die. You're not going to get anything. And do you know, we probably did 20 surveys on tablets. And I mean, a lot of these are sending teams out to we did a survey on a micro census where we were sending teams to randomly selected areas where we couldn't even tell them the village name. We just gave them a map. We're like, go here. We think it's around this village. And even to this day, I have zero idea how they kept their tablets charged, but people did. They were able to find batteries. They have these little, I don't know what the right term for them is, but they call them Chinese chargers, which is basically the little clips, and you put them on batteries and it charges the device once you're running a motorcycle. I mean, they've come up with all sorts of inventions to keep their tablets charged. And I mean, people told us in the beginning, they're like, there's no way this is going to work. And I mean, time after time after time, people are able to charge their tablets. And so there's just this, once they're in to do the work, they'll figure out a solution. And so, I mean, I have zero idea how they got to some of these villages, but we know they got there because we see the GPS points that they're there. So yeah, I'd say sometimes things just kind of happen by magic here. I don't know how they got there. I don't know how they charge their tablets, but they're able to do it. So I'd say those types of things for sure. And I mean, sometimes we'll see partners have ideas, and we're like, I don't know, we've tried some of these things out, and those weren't very successful. But sometimes people just have to fail before they'll see the way.
Awesome. Thank you so much.
Yeah, no problem. These are great questions.
Okay, sorry. Sorry, go ahead. I wanted to ask another question.
Oh, no, I was just saying, these are great questions. Oh, Doug, I see you ask any new music recommendations out of Kinshasa. I mean, Valley is always my favorite. Valley Ipupa is my favorite singer.
Leave it to Doug to ask that question. That is an excellent question. And hello, Doug.
Hey, everybody. Thank you, Nicole. I'll look into that. Nicole recommended Staff Bendability to me, 10 years ago? And that's one of my favorite groups.
I love Staff Bendability.
Yeah.
Do you see any biases maybe when you're conducting interviews, since you have to ask questions maybe in front of other family members, like maybe them telling you what you want to hear as opposed to the reality? Is that something that you've considered, and like how have you been able to control for it, like in your studies?
Yeah, every once in a while you'll come across situations where, especially like some of our vaccine studies, where like, like sometimes in these communities, like everybody knows, they're like, no, you didn't do it like that. You did it like this. And you're like, and so it's really interesting to try and tell the like interviewer, like how to kind of block out some of these outside voices. And I mean, we do as much as possible to be like, we can go somewhere separate. Do you want people around? Like, how do you want to do this survey? Like, how can we work with you to make you comfortable? And like I said, sometimes we have situations where people are like, oh, we don't want to be in private. That's really uncomfortable. And so, I mean, like, for example, with Adva and Dr. Amoyne, a few years ago, we did a study on schistosomiasis in pregnant women and STIs. And so for that study, it really, really required having women in an individual room because we were discussing really sensitive topics that weren't meant to like ever be public. But sometimes with the vaccination stuff, you'll find that it's like a community work of understanding a child being vaccinated. And I mean, in general, I'd say based on the vaccination rates we see of what's being reported, I can't imagine that they're lowering the vaccine rates with their responses on purpose, because you would think people know that they're supposed to get vaccinated or they know that they're supposed to do certain things. But we continually see fairly low rates of vaccine coverage, for example. So, I mean, like, definitely there's no perfect way to do things. But it definitely is a consideration of thinking like how much group involvement there is. I mean, some of our stuff for the microcensus study, it was like asking questions on, there was nothing like personal, and we didn't collect any identifying information. And so like, it was just like, oh, how many people live here? And it's interesting because, I mean, if somebody wasn't there, the neighbors are like, oh, this many people live there, and they know everything about that family. So it definitely, like, I mean, in each study, we kind of have different aspects. I'd say our Ebola healthcare worker studies, we were asking a lot more sensitive questions. And so we have a need to make sure that like people are a little bit distant or not like kind of hearing in on other parts of the surveys or what's going on. So I mean, I'm sure it plays a role, but I don't think it's probably affecting too much of what's going on or the results that we're getting. I haven't seen anywhere where it's blatant that like the people that we've hired as our local guides are specifically directing people to say something. Every once in a while, there'll be like an idea of like participation. To go into a lot of villages, you have to have the chef de village's approval, and you'll often have like a relay, like somebody come with you in the team. And so before we go into the field, like before we'll start going through the village with these people, we're like, the study is not obligatory. They don't have to participate. We just want to make sure that like, you know that we're here and that you approve that we're here, but don't tell people that this is obligatory. And every once in a while they'll be like, you have to participate. And we'll hear them and they're like, no, you don't have to participate if you don't want.
Yeah.
Saying that. And so, I mean, sometimes you'll end up in those situations where like the person that's walking with you, once they've accepted the study, they're like, oh yeah, you have to participate. I'm like, no, that's not true. It's voluntary. You can say no. So we've definitely had those situations where we've had to remind people it's completely voluntary. It's not forced.
Okay, sorry, another question. Like, do you use any kind of randomization when doing field work? And if that's the case, knowing that it's sometimes hard, because that's something that I've been struggling with when I'm being asked by my advisor how I'm going to sample, like how I'm going to do randomization, knowing that there are no street addresses, there are no like house addresses. Like, how do you do that in those places?
Yeah, I mean, we've done a number of things. Typically, we usually will start at the chef de village's house, and then they pick like the interviewers will pick a direction, and we'll say like every fifth house you pass by, or if we have an idea, like I mean, usually we have an idea of how many people live in a village, and so it'll be like every so many houses you stop by. Recently, we've actually done methods where we've like randomly selected a GPS point, had random GPS points like dropped, and then we have like a buffer area drawn around that where we assume like within the population there's going to be like if you need 50 houses or 50 buildings to meet our population size, that within the circle that they've drawn we'll have about that many houses, and then they actually will survey from everyone in that buffer area. So we've done, I mean, there's like a spinning method where you like spin a bottle to decide which direction you're going to start heading to do the surveys. Yeah, I mean, we've tried a few different methods. I haven't really figured out one being better than the other. Like, I mean, I've really liked when we've done the GIS point dropping, because they're pretty random points, because they're usually done by somebody in the US who's never been to Congo. So it's not likely that they would have any influence on where that point is being dropped. And then when they draw the buffer around it, we're like, okay, like, I mean, at some point, I also like, I mean, sometimes, of course, you'll find villages where everyone's the same. And sometimes even in those areas, you'll find a lot of variation, even within like a selected area. I mean, so I don't like our chances of trying to think what the right word is, of like finding a cluster where everybody's the same. We haven't really had any of these issues where we think that like typically if you see a village that in that cluster is well vaccinated, it's a probably pretty good indication that everyone around them is well vaccinated. And if you see a cluster where nobody is vaccinated within a village, it's probably a good indication that that village in general is not well vaccinated. If you see a lot of like heterogeneity within that cluster, it's probably a good idea that there's decent heterogeneity within that village. Yeah, we have those methods written up in our protocols, Carol.
Okay, that sounds good. Thank you.
Thank you.
Thank you so much for your time. I think I mean, I'm not surprised we're going over, because this is such an interesting topic, and I think it just brings up so many important questions. It's so nice to see so many of you here. Nicole, anything else you want to share before we finish up? Any other questions?
No, I'd say don't if you're in like still in the program or thinking about research or where you want to go. I mean, when I first came here, I didn't really speak any French or have any fieldwork experience, but I really love it, and it's definitely been an amazing opportunity. So, yeah. And I'm happy to, like, if you guys have questions or want to chat more, my email address is there. Yeah.
Nicole, this was a fantastic presentation. Thank you so much for your time, staying up late with us tonight to share your experience. We should probably have a follow-up in a couple of months when we start seeing vaccine rollout and understand what that's like. I think that'll be fantastic. Thanks to everybody that's joined. I see lots of familiar faces, old friends, and looking at some new friends here too. We welcome you always to join us for these COVID conversations, and And everybody stay safe and well. I hope to see you all again soon.